Good morning. I now convene today's hearing, Suicide Prevention and Treatment, Helping Loved Ones in Mental Health Crisis. Today, we take the conversation of suicide out of the dark shadow of stigma and into the bright light of truth and hope. Suicide is a deadly outcome of mental illness. Suicide is what happens when depression kills. Suicide is an epidemic, and its impact is staggering. But in 2013, 9.3 million Americans had serious thoughts of suicide. 2.7 million Americans made plans of suicide. 1.3 million Americans attempted suicide, and nearly 40,000 died by suicide. Suicide is an American public health crisis. It is a world health crisis, and that results in more lost lives than motor vehicle crashes, homicide, or drug use. As we will hear today, it is the third leading cause of death for young people between ages 15 and 24, second leading cause of death for adults ages 25 to 34. And each day we lose 22 veterans to suicide. Suicide is the very definition of a mental health crisis. The problem is clear and the need for action is urgent, but our national response to this crisis has been tepid and ineffectual at best. The age-adjusted death rates for heart disease, cancer, stroke, and diabetes are all trending downward as a result of a focused public and political will to address them. Yet in that same period, the suicide rate has climbed a stunning 16%. Suicides and suicidal behavior remain underreported, undertreated, and cloaked in a stigma that infects our discussion of all aspects of serious mental illness. The existing data collection instruments we use are weak. Our research is lagging. Helping families in mental health crisis remains my highest legislative priority, and if we have the courage to confront mental illness head-on, I'm certain we can save precious lives. Mentally ill, even when we know that there are genetics and neurological components that cause this illness. It is a brain disease. It is not a non-consensus reality. Mental illness is not a state of mind. And people who believe those concepts, that we can just will it away with awareness. I say that such thoughts are unscientific, it is uninformed, it is immoral, it is unethical, and it is wrong. So today, to provide some perspective on serious mental illness and suicidal behavior and to begin to dispel the most persistent and pervasive myths, as well as effective strategies for suicide prevention, we hear from a number of witnesses. First will be the Honorable Lincoln Diaz-Balart, our colleague and our friend, who formerly represented Florida's 21st District in Congress. Rear Admiral Boris Lushniak, the Acting Surgeon General. Dr. David Brent, the Endowed Chair in Suicide Studies at the University of Pittsburgh and Director of the STAR Center, a suicide prevention program for teens and young children. Dr. Christine Motier, Chief Medical Officer of the American Foundation for Suicide Prevention, and Joel Dvoskin of the University of Arizona. And now I'd like to give Ranking Member Diana DeGette an opportunity to deliver remarks of her own.
Suicide takes the lives of about 40,000 Americans every year, and of course that leaves behind millions of devastated parents, children, spouses, and friends. We've learned about the need to appropriately target mental health funding and the need to adequately fund mental health research.
I also want to highlight a particular population that is often overlooked when we discuss suicide and suicide prevention, and that is the nation's physicians. America's doctors, the people on the front lines of suicide prevention, are some of the most at risk of suicide and having suicidal thoughts. This is troubling, and I hope we can hear how it is being addressed. Physicians and dentists are the most likely occupations to take their own lives. Physicians are more than twice as likely, and as it turns out, female physicians are more than 3 times likely to commit suicide, and it also affects a disproportionate share of young doctors. Perhaps the most prominent challenge is that not every patient can be fixed. Watching patients suffer can be very isolating, and it can take a toll.
I want us to think about this, 105. That's the number of individuals that will take their life today, 105. Many more will attempt it. What we have not seen is a reduction in the suicide rates, the numbers of suicides that are attempted and committed. And I know we're all seeking to find answers to this. We each have been touched by those that have attempted or have committed suicide, and it is a very tender issue.
It takes a special kind of guts. You're coming here and talking about Your son, Lincoln, who suffered from mental illness, committed suicide last year, and I can only imagine the pain of losing a child to suicide. My heart goes out to you.
11. He is here today to share, for the first time, a moving and personal story about Lincoln Gabriel.
Mr. Chairman and Ranking Member DeGette, members of the committee, when you called, Mr. Chairman, last week and graciously asked if I would consider speaking here today, I consulted with my son Daniel. He and his older brother, our dearly beloved Lincoln Gabriel, LG, were very close. And I have ultimate trust in Daniel's judgment. Of course LG would want you to be there. If one person who might not otherwise get help is able to get treatment because of that hearing and its aftermath, LG would be happy. He was all love. His was not a theoretical love, it was a constant practical love, demonstrated by his daily actions. Christina, Daniel, and I miss him dearly, and we will continue to miss him for the rest of our days. I have never met anyone more respectful of all human beings than my son Lincoln Gabriel. As I said, he was all love. I must admit, I believed that all you need is love. I never thought our tragedy of May 19, 2013 was possible. But it was possible. Sometimes love is not enough. Assertive, proactive intervention is sometimes required to get needed treatment to those in mental health crisis, and thorough discussion of their illness with those who are sick. All those working to prevent tragedies such as the one my family experienced. Please find common ground. Overcome differences in order to make progress. As my son Daniel said, if one person who might not otherwise get help is able to get treatment because of this hearing and its aftermath, LG would be happy. Thank you.
Joined today by Rear Admiral Boris Lushniak, who is the acting United States Surgeon General. He oversees the operation of the U.S. Public Health Service Commission Corps, comprised of approximately 6,800 uniformed health officers.
What a way to start in terms of hearing the words of the Honorable Lincoln Diaz-Balart. You know, oftentimes in public health we get caught up, certainly in subcommittees we get caught up. We get caught up in numbers, we get caught up in programs, we get caught up in initiatives and successes and failures. I submit to you, sir, starting off with a personal and poignant story, such as presented to us, really sets the tone for what all this is about, that this ends up being that one life at a time. And yet we know that although he came here very heroically to discuss the story of his son and their family's tragedy, the repercussions of that spread out. And each and every year, as we already heard, almost 40,000 people have stories like that. Let's remember those 40,000. Let's focus on the public health impact of this terrible scourge in our land. The 2012 National Strategy for Suicide Prevention. And it goes like this. To those who have lost their lives by suicide, to those who struggle with thoughts of suicide, to those who have made an attempt on their lives, to those caring for someone who struggles, to those left behind after a death by suicide, to those in recovery, and to all those who work tirelessly to prevent suicide and suicide attempts in our nation. But here committed to demonstrate the commitment of the Office of the Surgeon General to continue to be visible and a long-term supporter of our nation's work in suicide prevention services. The ability of that title, of acting Surgeon General or the Surgeon General to bring the nation's attention and focus onto important public health issues remains an important and necessary part of our efforts to prevent suicide in our nation. In spite of an encouraging trend between 1995 and 2005, has sadly remained largely undisturbed. Many people will ask, why? The unsatisfying answer is suicide is a complex problem that defies a simple solution. Still, there are many clues out there in the international realm. The United Kingdom, steady significant reductions in suicide rates, included access to 24-hour crisis care, assertive outreach for people with severe mental illness. Taiwan, follow-up aftercare after suicide attempts led to a 63% reduction. Means reduction has been successful in international settings. Regardless of the means, those who die by suicide are far from being the only ones affected by that tragedy. We are engaged in a long-term effort to change how our society thinks about serious mental illness and suicides. We have to work on those changes.
If you could wrap up, Deputy.
While much has been done, we know more needs to be done. I applaud you for bringing attention to this issue. I urge your continued support for suicide prevention. Thank you, Mr. Chairman, Ranking Member DeGette, and members of the subcommittee, and I look forward to further discussion.
Thank you, Doctor. Also, Dr. David Brent is the Endowed Chair in Suicide Studies and Professor of Psychiatry, Pediatrics, Epidemiology, and Clinical and Translational Science at the University of Pittsburgh.
Some recommendations that may help us to reduce the suicide rate, which has to do with improved recognition and treatment. And I think the most promising area in this is in collaborative care, where mental health treatment is co-located in primary care. Dissemination of evidence-based treatments that have been shown to reduce suicide, coordination of care, and the system, mental health system, service system innovations that have been shown in England to reduce suicide. And I think that there are some research areas that could have relatively high payoff quickly. One is in whether better recognition and treatment of insomnia could have an effect on the suicide rate, safety counseling in primary care, whether restriction of availability of lethal means could reduce the suicide rate, and I think research on trying to find agents that have a more rapid onset of antidepressant effect than the ones that we're currently using. And I think that, finally, evidence-based prevention judiciously used. I think these recommendations, many of them are partly in place now, I think could make a favorable impact on the suicide rate. Thank you.
Thank you, Doctor. Dr. Christine Motier is the Chief Medical Officer of the American Foundation of Suicide Prevention.
The magnitude of suicide's toll on our society is immense, but my message today is hopeful and actionable. While suicide's roots are complex, with biological, psychological, and social determinants at play, clearly, oftentimes, suicide is the result of an unrecognized or untreated mental illness. And when 1 in 4 Americans have a diagnosable mental health condition, but only 1 in 5 of those are seeking professional help, we have a lot of work to do. We must highlight help seeking as the smart, responsible thing to do when you sense a change in mental health, just like you'd be proactive with any other aspect of your health problems. On a population level, we can implement more upstream approaches, such as shoring up community and peer support, teaching students social and emotional skills, making mental health care accessible and available to all, and addressing the healthcare system's failures, training frontline citizens like teachers, first responders, and clinicians, and limiting access to lethal means. The good news is that suicide is preventable, and thanks to a grassroots movement catalyzed by both suicide loss survivors and the emerging voice of those with their own history of suicide attempt, the fight against suicide is reaching a tipping point to bend the curve of our nation's suicide rate, and these areas include suicide prevention research, suicide prevention programs, and support programs for those who are touched by suicide. Suicide research must focus on the gaps in the science, which, if understood, would have the greatest potential impact on reducing suicide burden. Increase funding of suicide research in the hopes of obtaining similar reductions in mortality that have come from strategic investments in other major public health problems, like heart disease, HIV/AIDS, and cancer. Prevailing cultural perceptions about suicide and mental health keep 80% of people with a mental health problem from getting help. To address this appalling level of mental health illiteracy, we must provide education universally to eradicate stigma and shatter the real and perceived barriers that keep people suffering in silence. Suicide touches many, many lives, but only recently, as more and more people are speaking out about their experiences, has the need for action become so apparent. 10 years ago, our organization had only a handful of people banding together. Today, we have over 100,000 people walking and raising awareness for suicide prevention every year. It's time to wage war on suicide and put a stop to this tragic loss of life. Science can provide a clear roadmap, and I believe the American people are ready for a greater understanding of the issue. If we push hard with an effective strategy, we can save lives. Thank you.
Thank you. How can the American Foundation of Suicide Prevention and similar groups bring the myths and facts about suicide and suicide prevention to the attention of organizations and commentators active on social media? Could you please comment on how we need to change that?
Yes, I think that speaks exactly to the disconnect and the level of ignorance that's out there. We are doing things like working with the media. We just attended a conference this week to try to raise this level of education. We have friends in the Associated Press who are working to, for example, get the phrase committed suicide banned from the AP Style Guide, which would be a measure of progress as well.
I think access to be able to diagnose appropriately severe mental illness, to be able to treat it appropriately is the key feature. Yes. Suicides that do occur have had access to medical care.
Right. But they don't necessarily have access to psychological care.
But also the issue here is whether that issue, as you're having your blood pressure taken, whether
they're asking about that.
Exactly.
That's correct.
It's one of the things that we haven't discussed in detail, but is a part of that and I'm not going to pronounce the word right, but multi-reasons why someone might commit suicide. Do you believe that there is a gene that we might be able to identify that would say these folks with depression are more likely to commit suicide than other folks?
Certainly there are genetic influences on a variety of conditions. Substance use, abuse of substances, alcoholism obviously has a genetic predisposition. There are also mental health disorders, severe mental health disorders that do have a genetic genetic connection there as well.
I think there are things that we need to do now, and continuing and to more robustly fund research is very important. We're probably some years away from that genetic answer for predicting suicide risk, but it could be there, absolutely.
The Department of Veterans Affairs estimates that 22 veterans commit suicide every day. I'm not going to use that, I've learned. What is the proper way to say it then?
Died by suicide.
22 veterans died by suicide every day, about 7,000 per year. Veterans are 3 times as likely to die by suicide as non-veterans. The number of suicides among veterans is outpacing the number of combat deaths. So this is a real national tragedy.
Access to care doesn't mean very much if you can't get to a psychiatrist or a psychologist, and there aren't nearly enough mental health professionals in the United States. Not nearly enough. It takes 5 years to expand a residency program in psychiatry, and medical schools are loath to go into the process, so we're automatically, something we've done to ourselves, 5 years behind the curve to increase the number of psychiatrists that are being trained at some of these wonderful medical schools. And you can't bill for a resident. You can't bill Medicaid for the services provided by a resident. Well, this is something we're doing to ourselves.
Signed on as a co-sponsor of this legislation, a hugely important issue, and I thank him for that. Let me, Dr. Moutier, is that?
Moutier.
Moutier, yes. Let me ask you a few questions. Why has there been a consistently high suicide rate for elderly white men relative to all other groups? Any information on that?
The largest rise that we've seen in suicide rates, perhaps ever, which is in middle-aged men, actually, 35 to 64 years old. Over the last decade, their rates of suicide rose almost 50%. I would speak to a number of things, including all of the basic things that you've already heard about the prevalence rates of mental health problems and distress, and what happens when we don't take proactive care of ourselves. I would cite the role of culture, that we've had in particular segments of society, and we think about military, veteran, physician, and first responder populations, what they all have in common is higher rates of suicide than the general population and a very tough, macho, sort of can't acknowledge being a human being type of culture.
Dr.
Lushniak, yeah.
What the heck, Dr. L?
That ends up, and I'll sort of go back to the Robin Williams tragedy recently, right, is the fact that there was another peak right after that tragedy of call-ins to that lifeline.
Many of you mentioned the impact that suicide has not only on the victim, but the toll it takes on surrounding family, friends, and community. I would venture to say that everyone in this room today has been personally affected by suicide at some point in his or her life. The numbers surrounding this epidemic are astounding. While we are in this hearing today, it's estimated that 9 people across this country will complete suicide. What more do we need to do to ensure that there will be an adequate supply of providers to handle the mental health needs of our community?
I think it starts with both improved training of the existing healthcare workforce as well as down the pipeline, the medical students and other disciplines who are coming up. People may be shocked to know that in only 2 states in our country is suicide education, a small module on suicide, even mandated for mental health clinicians who are in training. So we have so much work to do, and in some ways I would say that should give us hope because we can do that kind of thing.
And this framework for successful messaging, it's an initiative designed to advance this national strategy of changing the public conversation about suicide prevention. The alliance that I had mentioned, this National Action Alliance for Suicide Prevention, the private-public partnership, in fact, has an institute that is now set up to provide journalists with crucial training to effectively communicate to the public about suicide and mental health. I think there's 2 aspects to this from a public health perspective, public health communication perspective. One of which is we can't stigmatize the concepts of severe mental illness, mental health issues, nor stigmatize a conversation about suicide. Long gone are the days that these are whispered in hallways. Oh, did you hear what happened? This is terrible. We need to bring it front and center as a public health issue with scientific evidence that can solve that public health issue.
Now, I want to end this with an important note. I'm going to ask you each simple question. Can we prevent suicide with proper intervention? Dr. Lushniak?
Without a doubt, sir.
Dr. Brent? Yes. Dr. Moutier?
Absolutely, yes.
Dr. Dvorsky?
Yes.
Does treatment work for people with mental illness? Dr. Lushniak?
Yes.
Brent? Dr.
Some of the time, but it's better than no treatment.
Good. Dr. Moutier?
Yes, and it needs to be the right treatment.
Thank you. And Dr. Dvorsky?
Yes.
And that is important what you said. The proper treatment will work. And that's what we have to get people to access with the right trained professionals. Dr. Moutier, what is that phone number people can call?
1-800-273-TALK, and that is the National Suicide Prevention Lifeline.
And there's lifelines in people's communities as well they can look up. I'd like to thank all the witnesses and members that participated in today's hearing. To the questions. Thank you so much for your dedication and passion. And with that, I adjourn this hearing.